Good morning and welcome to the 2017 series of Epilepsy Grand Rounds at George Washington. This morning it's my great pleasure to introduce Dr. Aatif Husain, Professor of Neurology at Duke University. Dr. Husain earned his medical degree from Pakistan and then did his neurology residency at Medical College of Pennsylvania in Philadelphia before he pursued clinical neurophysiology and sleep fellowship at Duke, followed by EMG and neuromuscular fellowship at Duke. He stayed at Duke on faculty, and he's now professor of neurology and program director for the clinical neurophysiology and sleep fellowships. He's also the director of the Southeast Epilepsy Center of Excellence at the VA. Throughout his career, Dr. Husain has been consistently productive in research, asking questions that are very relevant to clinical practice and publishing his findings in major journals. He has edited major textbooks, very commonly used ones, and has trained numerous fellows who have gone on to become leaders in the field as well. Dr. Husain also succeeded in securing extramural funding for his research, part of which we're going to learn about today. Dr. Husain.
Thank you very much, Mohammed, for that generous introduction, and it's always a pleasure to come to Washington in my second Grand Rounds at George Washington University. Thank you all for dealing with the cold this morning. Coming from North Carolina, this is exceptionally cold for me. I'm not sure it is for you, but it is for me. But nonetheless, what I wanted to do today is talk about a topic that is very close to my heart, and that is appropriately aggressive treatment of seizures in critically ill patients. Notice I did not say appropriately aggressive treatment of status epilepticus, because that is sort of the distinction that I want to draw. I know you've heard a number of wonderful presentations in the last year on status epilepticus and the treatment of, and perhaps I'll be able to add a little bit to that. Before I start, there's a few CME announcements that I'm sure you've seen before. I will go through these relatively quickly. Upcoming events you see here. Disclosures, I will show you my own disclosures in just a bit. These are the disclosures of the folks who are organizing this activity, which is also very important from an ACCME perspective. Here are the learning objectives, and I won't go over these in detail. Hopefully you'll learn all of these in the next 55 minutes or so. This is an accreditation statement from George Washington University. Skip over that. And to claim CME credit, these are your instructions. I'll linger on this for just a minute. And then move on to my disclosures. I'm actually going to leave the slide up for just a bit because, unlike many other presentations, this is relevant to today's talk. It is relevant because I will be discussing a number of medications whose companies have given me grants to study these drugs. And so there is an inherent bias in what I present, but I want to put that out there in the beginning so that is evident as you listen. My other disclosure is that I've consulted with, I believe, every major pharmaceutical company that is in the process of or has in the past made a drug for status epilepticus. And yet another word of caution for the regulators, since we are in Washington, D.C. Unlabeled use of anti-epileptic medications will be discussed. As you know, there are very few, if any, approved medications for status epilepticus, so I will be talking about drugs that will be used off-label. Okay, so let's get started. How aggressive should we be when we treat patients who have seizures in an intensive care unit setting or critically ill patients? And I'll start by presenting a poster that I saw a couple of years ago, and this is from VCU, from the folks in Richmond. And this is Elizabeth Waterhouse's work, and she presented this and was nice enough to share her poster with me. You can't read much of it, but I will summarize what the main findings of this poster are. This is simply a case report. And this is one gentleman that they've seen in the ER frequently, so-called frequent flyer, if you will. This is a 57, 58-year-old man who had a prior history of a left frontoparietal hemorrhagic stroke and developed epilepsy from that. He's relatively non-compliant with his medication, is on 2 or 3 drugs, but stops taking them periodically. The first non-ICU admission box that you see there is him presenting to the emergency department with a flurry of seizures because he had forgotten or he had not taken his anti-seizure medications. His seizures manifest as episodes of aphasia, which are not strokes. These are electrographic events, and they resolve. There's no loss of consciousness per se. There's no tonic-clonic activity, but he's unable to speak. He does this. He's seen in the emergency room. He's treated urgently with benzodiazepine, loaded with phenytoin, and admitted to the hospital. EEG monitoring is done, confirms recurrent electrographic seizures. They treat it a little more aggressively, give him more non-sedating AEDs, and by day 9, his seizures are finally under control, and by day 16, he leaves the hospital back home. A few months later, he represents, again having stopped his medications. This time he's seen in the ICU or in the emergency department for episodes of stopping talking, much like he had presented before. And indeed, EEG monitoring shows that he's again having recurrent seizures from the same location. This time he's treated more aggressively because the attending on call is someone different. He's admitted to the intensive care unit and put on sedative medications very quickly. And by day 6 or so, his seizures are brought under control, but he has numerous other problems. He develops sepsis, he develops a pneumonia, he develops hypotension, he develops numerous other problems, and this is the summary of the 2 stays. Length of stay was 16 days for the non-ICU admission, 36 days for the ICU admission. No comorbidities in the non-ICU admission, and you see the list of comorbidities in the ICU admission. You see the cost for the non-ICU admission, and you see the cost for the ICU admission. He went home when he was admitted to the ward. He went to a skilled nursing facility when he was admitted to the ICU. So is aggressive treatment always warranted? Should you always think about putting these patients down, so to speak, when they present with a flurry of seizures or recurrent seizures? And that's what we will talk about. How aggressive should you be? Appropriately aggressive, of course, and that's sort of a tongue-in-cheek, but hopefully I will stress to you what appropriately aggressive means throughout this talk. This is a quote from someone that I think has done wonderful work in this area, Peter Kaplan, just up the street from you folks at Bayview in Baltimore. And this is from almost 20 years ago. And he states that the equation that has not yet been calculated is whether the small incidence of permanent cognitive side effects constitutes a greater morbidity than the small incidence of respiratory suppression, hypotension, cardiac arrhythmia, and even deaths that are followed by intravenous anti-seizure medication. So even 20 years ago, there's realization that, yes, we must treat these people aggressively, but there is certainly a morbidity to what we do. And so let's give you an overview of what I will go over in the next 50 minutes or so. I'm going to talk a little bit about definitions of seizures and status epilepticus in particular. I'm going to talk a little bit about seizure severity. Is there a way to measure status epilepticus other than as a monolithic entity of status or no status? And then we're going to talk about treatment decisions and how we base these treatment decisions based on how status is responding to the medications that we are giving them. And finally, what can I tell you about appropriately aggressive treatment? And we'll end with that. So let's start off by talking about the definitions of status. So I'll give you a short, very short history lesson, a 2-slide history lesson about the definition of status. So the first sort of published definition is in 1964, and that's the International League Against Epilepsy, at the time publishing a definition that simply says that a seizure that persists for a sufficient length of time and is repeated frequently enough to produce a fixed and enduring epileptic condition. So notice that there are no time markers on this definition. And if you look at the next definition from 1981, that also does not have time markers, and that's again from the ILAE, a seizure that persists for a sufficient length of time or is repeated frequently enough. So the main difference here is that you've introduced the concept of recurrent episodes rather than a single monolithic episode. The definition that we're all probably very familiar with is from 1993, so it's actually not that old a definition, and this says that a status episode is more than 30 minutes of one continuous seizure activity or two or more sequential seizures without full recovery of consciousness. Okay, so this is probably the definition that most people think of when they think of status. But notice what is not included here is what is happening actually in the brain. In other words, what's happening with the EEG and what sort of neurologic morbidity is happening with each minute of status that goes on. Dr. Lowenstein from California in 1999 said, this 30-minute marker is probably not appropriate and not the message we want to be sending. We really want to start treatment of status much sooner than 30 minutes and suggested a revision to the definition by saying that generalized convulsive status in adults and older children refers to more than 5 minutes of continuous seizures or 2 or more discrete seizures without complete recovery. Notice the difference here is that he's referring to generalized convulsive status. This is not status that you're seeing in the intensive care unit. This is not the seizures that you're seeing in the intensive care unit. The Neurocritical Care Society about 4 or 5 years ago revised the definition again and suggested that 5 minutes or more of continuous clinical and or electrographic seizure activity or recurrent seizure activity without returning to baseline. So notice the huge jump from 1999 to 2012 in that you go from convulsive status epilepticus to electrographic seizures. Huge jump. And I would argue there isn't a whole lot of scientific background and background research that prompted that transition. And what I'm going to try to show you is why I think that that's probably something that you should think long and hard about before you jump to calling that status epilepticus. So what is status? We used to think of status as this entity that starts, goes on for 30 or more minutes, and then you somehow terminate it. And the brain is undergoing some bad thing for this 30-minute period of time. Indeed, that may be what's going on, but we also consider this status. You have an episode, you don't recover. You have another episode, you don't recover. You have a third episode, you don't recover. This could go on for an hour or half hour, and that would still be called status. And I would argue, are these two the same? Is the amount of brain injury that's happening the same if it's recurrent or if it's intermittent? Or if there are long episodes with long episodes of nothing happening in the brain but the patient not waking up, is that the same as 2 short episodes? Or if you have half an episode that doesn't lead to waking up, is that the same? If you have both hemispheres involved, is that the same as having one hemisphere involved or part of one hemisphere involved? And so on and so forth. So you can see that there could be many iterations of this. And the question is, do all of these lead to the same neurologic morbidity? And so this is finally being addressed with the latest revision to the definition of status by the ILAE. And this is from Dr. Trinka's work in Austria. And they note that status is a condition resulting either from failure of mechanisms to stop seizures or other mechanisms that lead to their perpetuation. And they introduced 2 very important concepts, the concept of T1 and the concept of T2. What are these 2 concepts? T1 is the time frame beyond which a seizure should be regarded as continuous. In other words, this is not going to stop on its own. That's time 1. Time 2, which is a different time point, is a time point beyond which ongoing seizure activity leads to long-term consequences. In other words, lead to some type of neuronal injury. T1 and T2 are not the same. These are 2 different time points. And they, in fact, point this out in their paper, as if you look at different types of status, if you look at tonic-clonic status, the status that Dr. Lowenstein was referring to in 1999 when he suggested a revision of the definition, T1, time point beyond which it will not stop by itself, is probably 5 minutes. T2, time point beyond which it is actually causing neuronal injury, is probably 30 minutes. So now you've got yourself a time window. You must act between 5 and 30 minutes. 5 minutes, you know that this is not going away on its own. 30 minutes, you know that if I have not stopped it by now, this will cause permanent neurologic injury. And they point that out with focal status epilepticus as well and for absence status. And notice that time 1 and time 2 are different for different conditions, different for different severities of status. So for absence status, we don't know what T2 is. We don't know that absence status will ever cause neuronal injury. But for focal status, we know that T2 may be beyond 60 minutes. And when we think about non-convulsive seizures in the ICU, we have no idea what T1 is, and we have no idea what T2 is. So already the concept of T1 and T2 has been introduced. Already we're thinking about the fact that seizures and status are going to be different, and our approach to it should be different. So how do we measure seizure severity? How can we get ahead of this? How can we start thinking about this? Well, here's one way to think about it. We all know that convulsive status epilepticus, we just talked about this, is a neurologic emergency, and it must be managed urgently and quickly. There is high morbidity and high urgency for treatment. On the other hand, all of us see patients in the outpatient setting where patients are presenting with probably breakthrough seizures every now and then. And when we hear about a breakthrough seizure, we have a relatively low urgency because we think that the morbidity of that is relatively low as well. And so we'll tinker with the medications on an outpatient basis. But what we don't know, what we don't have an idea of, is this big gray area in the middle. And so in this big gray area, you've got non-convulsive recurrent seizures. These start to merge, and then you have non-convulsive status epilepticus. What is the morbidity of each of these conditions? And what is the urgency of treatment? This is one big black box, and that's what we need to try to unravel. And to do that, should we start thinking of not status epilepticus, but perhaps an acute seizure emergency and a degree of seizure burden? In other words, what is this amount of time seizing per hour of recording or per hour of time? Is that another way to look at it? So we tried to do this at our center a number of years ago. Dr. Kubesi's prior colleague, Dr. Sinha, put this poster together a number of years ago. And what our idea was is that we're going to start to look at status not simply as on and off or yes and no, but how many minutes of each hour are you seizing? How much of your brain is seizing? What EEG activity do you have? And that I have not touched on yet. Is a seizure that has a rhythmic alpha frequency versus a seizure that has a rhythmic theta frequency, are they causing the same amount of neuronal injury? Not something we think about, but clearly there's a different pattern going on. Something different is happening to generate different rhythms. Why is that happening, and what is the underlying consequence of that? Should we be thinking about that? So we took that into account. We took into account the non-seizure time between the seizures and combined all of this together in a score, and then took the median of that score. The higher, the folks above the 50% mark were considered more severe. Folks below the 50% mark were considered less severe. And what you see are the two separations of these groups. The one on your left is the one with the lower score. The one on your right is the one with the higher score. Purple and green are favorable outcomes. In other words, either going home or to a rehab facility. The red and blue outcomes are either death or skilled nursing facility. So we start to see a trend that the higher your score, perhaps the worse the outcome. So this was also looked at by a very nice paper in Brain recently by the group at Sick Kids in Toronto. And they looked at the amount of time seizing for their children, average age about 2.5, 3 years old, and whether these kids had neurologic morbidity. And they found that if the kid was seizing about 20% of an hour, the risk of neurologic injury was much higher than if the kid didn't seize at all, or if it was less than 20%. 20% equals about 12 minutes per hour. And you see this nice dichotomy over here between less than 20% and higher than 20%. And in fact, when they plotted their curves, you see that there's three conditions they looked at: acute brain injury, acute seizures, and systemic disease. For acute seizures and systemic disease, there's a very nice curve of increasing seizure burden, increasing morbidity. It is also true for acute brain injury, but in acute brain injury, the underlying condition results for a lot of the neurologic morbidity rather than the status on top of it. Nick Aben's group at CHOP in Philadelphia has also looked at this in a number of ways. The first study that is shown here is a single-center study. The second is a multi-center study, and they both found the same thing. In their children who had seizures, the ones that had status epilepticus, defined as more than 30 minutes of seizure time, versus those that had electrographic seizures, had a difference in outcome. The ones who had status had more cognitive impairment and more neurologic morbidity than the kids who only had electrographic seizures. They looked at this in more detail in follow-up, and 2.5, 3 years after the admission, they went back and looked at these kids. They had, I think, 67 or 68 kids that they could get follow-up on, and 2.5 years later, these kids have a lower IQ or doing worse if they had status versus if they had electrographic seizures. So again, now we're getting long-term outcome data that indeed, the longer you're seizing, the worse off you're going to be long-term. There's also data from indwelling electrodes. So these are data from depth electrodes from UCLA and from Columbia. And what they have looked at is depth electrodes that are put in with other monitoring devices such as a Lycox, and they are looking at not only electrographic seizures with these depth electrodes near sites of brain injury, but they're also looking at ICP, they're looking at glucose utilization, lactate pyruvate ratio, and this area in gray that you see are seizure times, and this area in light gray that you see are non-seizure times. And you see what happens to the LPR, the lactate pyruvate ratio. A marker of brain injury goes up as the seizure continues, and then as you get into the non-ictal periods, it comes back down. And when they looked at their 7 or 8 patients that they had this monitoring on, there's clearly a difference between LPRs before and during periods of electrographic seizure activity. And these are electrographic seizures that may not even be evident on scalp. These are only being picked up with small microelectrodes, intracortical electrodes. So I'll wrap up this section by showing you this nice paper from JAMA Neurology from a couple of years ago. And this points out that indeed the incidence of status has been going up. The reported cases of status have been going up. You see that from 2005 to 2007 to 2009 to 2011, all bars are trending up, and the different bars are patients who are intubated with status, non-intubated, primary status, non-primary status. In other words, status as a result of an acute neurologic or medical illness, or primary status epilepticus. So bottom line is all bars are trending up. Some are trending up more steeply, and these are non-primary status, so these are the critically ill patients that we're finding more and more of. And the author's prediction is that this is because we have more sophisticated monitoring devices. We have more continuous EEG monitoring, we're picking these up more. But very interestingly, they also note that if you look at the mortality of status, it is relatively flat. Even though the number of patients that have status keeps going up, we're better able to take care of them. Now, is it that the mortality is of a certain group of status patients that is not necessarily increasing, or we're picking up the status patients that are not of the same degree of morbidity and mortality that we were thinking of status was 20 years ago, when the only status we really thought about was convulsive status epilepticus. So these are issues being raised, is that indeed, if you look at mortality, it is relatively flat, but if you look at incidence, it keeps going up. All right, so let's talk a little bit about treatment decisions and how do we think about treating patients who show up with acute seizures and status epilepticus. One way to look at it is that we have treatments based on the phase or the state of status epilepticus. We have treatments for early, we have treatments for established, for refractory, and then super refractory. So I'll just take a minute and explain these terms for you because we'll be coming back to these throughout the talk. Early status is status that typically has not been treated at all. And this is often status that now is being treated not in the emergency room, not in the hospital, but in the patient's home. This is being treated by the EMTs either at the patient's home or en route to the emergency room. This is not something you as a neurology resident or as a neurologist would necessarily be involved with. This is more critical care emergency department domain. This is most often benzodiazepines. There's very nice studies that have been done with the use of benzodiazepines. There's one that was published relatively recently, the Rampart trial. There's others that have been published 10, 15 years ago. They have unequivocally established that benzodiazepines are the preferred drug. Which benzodiazepine? That remains to be determined. And which route of administration? That remains to be determined. But again, that is not something that as a neurologist you are going to be in the position for deciding very often. So I'm going to skip and talk more about established status epilepticus. And this is after the benzodiazepine has failed. So the patient has been treated in the field en route to the emergency department, but when they arrive in the emergency department, they are still seizing. And that is generally defined as clinical seizure activity. When they arrive in the emergency department, they don't have an EEG on them. So if they have clinical seizure activity, they are considered to be an established status epilepticus. Refractory status is now you've treated the established with first-line, second-line therapy, and now you need a third-line drug because it has not stopped. Typically, your refractory status is with EEG monitoring. Your patient continues to have seizures, often electrographic, but maybe clinical as well. And then super refractory is the kitchen sink status. You've thrown everything you knew at it, and they're still seizing. And now you're thinking about intravenous anesthetics, and that's a super refractory status. So let's talk a little bit about established status. I said early status is not something that you will be typically involved with, so I'm going to skip over that. And here are the second-line drugs, if you will. So first line is benzodiazepines. Second-line drugs are these: phenytoin, fosphenytoin, valproate, levetiracetam, perhaps lacosamide, and phenobarbital. Few of us use phenobarbital as a second-line agent, but it is certainly available and certainly has been used extensively in the past. And really the one study that you must all be aware of is the Dave Tryman VA cooperative study that was done almost 20 years ago now. And they looked at a number of patients with overt, generalized, convulsive status epilepticus, and they randomized patients to receiving just lorazepam, just phenobarbital, diazepam followed by phenytoin, and phenytoin alone. And this was really the first study that in a randomized fashion looked at different treatment options for the treatment of convulsive clinical status epilepticus and found that lorazepam benzodiazepines were superior to phenytoin by itself. 64% versus 43% seizures were brought under control. This was not an EEG-based study. This was a clinical study. This was done in the 1990s. Continuous EEG monitoring had not yet arrived on the scene. There's a number of other papers that have been presented, but really no randomized prospective trial on status. This is a nice summary from Dr. Shorwan's group from London, and they have done a meta-analysis of various drugs that have reported outcomes based on large series or non-randomized trials. And you see various drugs listed here. There's obviously a reporting bias, but nonetheless, for non-prospective, non-randomized studies, this is the best data that you can get. You see your favorite drugs probably listed on here, such as levetiracetam, phenytoin, valproate, which are the more commonly used ones. And you notice that the efficacy, which is the number of patients that stopped seizing after they got this drug, 68% for levetiracetam, which is probably a lot higher than I would have thought. Phenytoin is 50%, and valproate is 75%. That's a little surprising. When I looked at this data, I've always thought of phenytoin as being the go-to drug, and most American neurologists regard phenytoin as our go-to drug. And it's certainly the drug that you don't want to be on a witness stand for not having administered for a patient who has complications. So phenytoin certainly has a role in U.S. neurology that it perhaps doesn't outside of the U.S. But nonetheless, the hard data on phenytoin is not that great. Lacosamide, they did not have a lot of data in 2014, so there really isn't much to talk about here. Refractory status, so your second-line agent has failed. So now what are you going to use? Here's your list of drugs for third-line therapy, in fact. So you've got the same list of drugs. You've got a few additions. You've got lacosamide here. There's more data for lacosamide now. Levetiracetam remains here. And there are two new drugs that are being thought of in this space. IV carbamazepine, so certainly not a new drug, but certainly a new formulation. IV carbamazepine is now approved, though not available, and pretty soon it will be on the market for us to use. Is there any data on status epilepticus? Absolutely none. Is there any loading data? Indeed. It's been around for many years, but all the loading data is for PO carbamazepine. There's no IV loading data on carbamazepine yet. And then there's neurosteroids that I'll talk about in a minute. And then there's other options. These are non-IV options generally, but they're certainly available, that there's some case series and some data on. I'm not going to go into all of these in detail. I do want to talk, as Mohammed alluded to at the start of the talk, on this trial that we did for lacosamide. So this was an investigator-initiated, multi-center, randomized prospective trial that was EEG-based. And this was not patients in status epilepticus, but patients who were having non-convulsive seizures. So the answer, or the question that we wanted answered, is we have a bunch of patients in the intensive care units. We see that they're seizing on continuous EEG monitoring every day. How do we treat these patients? They're not recovering. They're not waking up after every electrographic seizure because they're neurologically or medically ill. They're encephalopathic to begin with, and they've got seizures superimposed on their encephalopathy. So this measure, this clinical measure that patients are awake or not awake, is not applicable to our intensive care unit setting. So how do we treat these patients? That was the question we wanted answered, and is phenytoin the best drug? So this was a head-to-head comparison of lacosamide versus fosphenytoin. And when we started this, there was already some accumulating data on open-label case series and such, case reports on the value of lacosamide in these patients. And so we decided to do a multi-center trial done through the CCEMRC, which is a continuous, the Consortium for Continuous EEG Monitoring and Research. This was a 13-center study. We wanted to enroll 200 patients. We ended up enrolling 74. There's a long story behind that as well. But the primary aim of the study, or the primary arms of the study, I should say, was fosphenytoin loaded at a usual loading dose of 20 milligrams per kilogram, and lacosamide loaded at a dose of 400 milligrams IV. If after 2 hours the patient's seizures were not controlled, in other words, the patient had a breakthrough seizure, they got either 200 milligrams of lacosamide in addition to the 400 they had already received, or they got a 5 milligram per kilogram bolus of fosphenytoin in addition to the 20 milligrams per kilogram that they had already received. So the phos dose we thought was pretty similar to what is done in clinical practice. The lacosamide dose was the one that the company had previously studied as bolus dosing, but not in critically ill patients. Bottom line is our seizure-free rates you see up here. 63% of our lacosamide patients stopped seizing, 50% of our fosphenytoin patients stopped seizing. And this was designed as a non-inferiority study, as most epilepsy studies are, and this reached a significance for non-inferiority. So notice that the fosphenytoin response rate is remarkably similar to the meta-analysis that was done by Chorvan and colleagues a few years prior to this. And we also looked at our seizure burden, in other words, the amount of time seizing. This was a crossover study, so if one drug failed, we gave them the other. And we found that, indeed, the amount of seizure time decreased with both, but a little more for the lacosamide group than it did for the fosphenytoin group. Interestingly, we thought that the adverse events would be remarkably different, but in a series of 74 patients, when we were looking at a window of about 72 hours, we were not able to demonstrate a difference in the severity or the quality of side effects between the two drugs, which came as somewhat of a surprise given what we think about when we think about administering fosphenytoin to critically ill patients. There is an ongoing trial called the Established Status Epilepticus Treatment Trial, or ESET. ESET is looking at this population of established status epilepticus, meaning that they have failed benzodiazepines. They're now showing up to the emergency department, and they're going to get randomized to either dilantin, fosphenytoin, valproic acid, or levetiracetam. It's a 3-arm study. It is an ongoing study, and they have a number of sites throughout the country that you see listed here. We don't have any data from that study at this point. I'm going to switch gears and talk a little bit about superrefractory status epilepticus that has gained some popularity in the recent months and years. And remember that SRSE, or superrefractory status, is that status that is not responsive to any of the medications that you have used so far, and you're going to need IV anesthetic agents to put these patients, or to treat these patients. And the drugs that we commonly think about are midazolam, propofol, ketamine, barbiturates, and now neurosteroids. So neurosteroids are an interesting group of compounds. These are naturally occurring, but they can also be synthesized. They're a little bit different than benzodiazepines in that they do act on benzodiazepine receptors. However, they act on extrasynaptic benzodiazepine receptors. So whereas most benzodiazepines will act over here, neurosteroids act out here. And why is this important? This is important because very nice work from UVA and others have shown that these receptors, the benzodiazepine receptors that are synaptic, get internalized as status continues. In other words, they are no longer available for therapeutic efficacy. And so the only receptors for benzodiazepines that you have available are extrasynaptic receptors. And that is what the neurosteroids are supposed to be targeting. So there are two neurosteroids now that are being tested. The first is allopregnanolone. There is an ongoing trial, a randomized trial for allopregnanolone that is being conducted in about 150 centers throughout the world. But they have completed an open-label study of about 25 or so patients that's about to be published. But even before that study started, we enrolled a patient in emergency IND, or what used to be called compassionate use, before the open label study got underway. And this is that patient in terms of the treatment options that he had. This is a 28-year-old gentleman with superrefractory status. Came very close to dying a number of times. You see how he was treated. He was on pentobarbital for a long period of time. And over here on day 27 or so, we started him on allopregnanolone. Allopregnanolone is a 5-day infusion, and that's it. There's not an ongoing treatment. There's only IV formulation available. We treated him for 5 days and then tapered off. And around here, around day 30 or so, he stopped seizing. And I see him in my outpatient clinic now on a fairly routine basis, still having occasional breakthrough seizures, but certainly being productive and leading a relatively normal life. I realized last time he came for follow-up that he had returned completely back to normal. When he walks into clinic and is happily married, is about to have a kid, and hands me his disability form, then I knew for sure that he had become a standard epilepsy patient. So he is doing well. Ganaxolone is another neurosteroid. This is not naturally occurring like allopregnanolone. Ganaxolone has been in oral studies for a long period of time, and we looked at ganaxolone in a single patient, again, emergency IND use. This is a 17-year-old young man with intellectual disability who had been treated with just about everything, including pentobarbital, and they were getting ready to withdraw support when I suggested that we might want to try one more last-ditch effort with ganaxolone. This is someone who'd already received allopregnanolone in a double-blind study. So we don't really know if he got allo or not, but it didn't work, whether placebo or allo. So this is the patient, and this is his EEG. It doesn't look like a standard EEG. This is a quantitative EEG. And what I wanted to just point out to you, for those of you who are not used to looking at QEEG, is these little bars here represent electrographic seizures. Okay, this is the left side, this is the right side. So having many, many electrographic seizures at baseline. We gave him ganaxolone, and we gradually increased the dose from 60 milligrams an hour to 120 milligrams an hour. And even if you don't know anything about looking at EEGs, you must be impressed at the response to this patient's EEG. Now, obviously, this is a kid that did not improve. He's on anesthetics and so on and so forth, and despite all of this, he was seizing. You give him ganaxolone and his EEG cleans up remarkably. Now, there's lots of issues with ganaxolone in terms of what it's mixed with and so on and so forth. So within an hour or so, we had to come down on his dose, and when we started coming down, he started to seize again. We went back up on the dose of ganaxolone, and we could not bring back the control that we had after initial bolus. So we don't quite know what this means, but the response on EEG was certainly dramatic when initially given. So I'm going to switch gears again and talk for the last few minutes on appropriately aggressive therapy. So how do we figure out what appropriately aggressive therapy is? So let me show you a couple of examples where this becomes important. So this I'm showing you not because it's a very good study, but it was really one of the earliest studies where this was raised as an issue, and this is by Brian Litt, who is now at Penn, but I think this is work done when he was at Emory. And here he looked at patients that were critically ill, who were in status epilepticus. those that had an advance directive and those did not. The ones with an advance directive advising no heroic measures, no ICU admission, so on and so forth, were managed on the floor relatively conservatively, and those that did not have advanced directives were managed in the intensive care unit, presumably more aggressively. This was the only dichotomy between ICU patients and advanced directive patients. And the couple of things that I wanted to point out here are the percentage of patients that died was different. The number of acute problems was really not different between the two groups. And Brian's conclusion in his study was treatment with IV benzodiazepines may increase the risk of death. Aggressive ICU management may prolong hospitalization at considerable cost without improving outcome. So fairly dramatic statement, but certainly leaves open the question is, yes, they did not have advanced directives, but the patients going to the intensive care unit are patients generally that are sicker, more likely to die anyway. So what does this really establish? But it does certainly raise the question that certainly bringing them to the ICU doesn't automatically mean that they're going to have better outcomes. A more recent study, again, looking at the same issue, and they looked at here, Spatola and his group looked at whether or not exposure to excessive benzodiazepines versus a normal dose of benzodiazepines, excessive defined as more than 30% of recommended dosing. And again, their conclusion was, although administration of excessive benzodiazepines in status epilepticus does not seem to influence outcomes, in other words, give them a higher dose, they don't necessarily do better, they are at a higher risk of respiratory depression, longer hospitalization, and additional complications. And so the two things that were significant in this group were that the ones with excessive benzodiazepines had a higher risk of being comatose and a higher risk for needing intubation, as you might imagine. The two go hand in hand. Moving on, again, a relatively recent study from Europe. These folks looked at therapeutic coma and outcome. They looked to see, of their patients who were presenting in status, how did they do? One of the things that happens when you present with status epilepticus is potentially you get therapeutic coma with IV anesthetics. About 50 of their 467 patients underwent therapeutic coma. If you look at new disability and mortality in these status epilepticus patients, therapeutic coma, 6.86 relative risk of new disability, 9.1 relative risk of death with therapeutic coma versus those who did not have therapeutic coma. Again, raising the issue, therapeutic coma is done for patients who are ill, who are more sick than others. So to try to answer that, this next study by Suter and colleagues said we're going to try to control for that. This is their primary data. They have patients with and without IV anesthetic, and you see that the ones with IV anesthetic are about half as many as the ones without IV anesthetics up here. And you see that a few significant things here. Seizure control more often without anesthetics than with anesthetics. Death more often with anesthetic than without anesthetic. But when you control for stuff, when you control for status duration, status severity, critical illnesses, third-line AEDs, even then, if you look at death, the relative risk for death in patients who are getting therapeutic coma is still higher than those who are not getting therapeutic coma. And their conclusion is this study provides class 3 evidence that patients with status receiving IV anesthetic agents have a higher proportion of infection and an increased risk of death as compared to patients not receiving IV anesthetics. Well, there's always two sides of the story, and there's certainly people who have argued the converse. And this is data from Colombia, and they point out that they have got a series of patients that they have treated with relatively low-dose midazolam and relatively high-dose midazolam, low dose being defined as 0.2 milligrams per kilogram per hour, and high dose being on average 0.4 milligrams per kilogram per hour. The range is fairly wide, but that's sort of the average. And the reason they have these two groups is that they were using lower dosages in the late 1990s, early 2000s, and about 2004 onward, they started to use a more higher dose. And they noticed that really there's no significant difference between these two groups. There's certainly no difference in outcomes and mortality. However, the frequency with which withdrawal seizures, in other words, seizures after stopping the benzodiazepine, occur is higher with the low-dose group than with the high-dose group. And their conclusion is high-dose IV midazolam treatment of refractory status can be performed safely, is associated with a lower seizure rate after discontinuation of drug, and may be associated with lower mortality. So, somewhat of the opposite, that indeed high-dose benzodiazepines, if you know how to use them, are safe and effective. And Alvarez, again, this is in fact the same group that has previously shown that therapeutic coma is not so good, are now have a publication where they talk about therapeutic coma in Europe versus the US. So this is a Swiss hospital, CHUV, versus the Harvard-affiliated hospitals, HAH. And this paper is simply how are we using therapeutic coma in Europe versus how are we using it in the US. And here you see a number of different things that they looked at. And again, they are looking at a multivariate regression. There seems to be an association with a lot of different things, including comorbidity, status severity, potentially fatal etiology, all of these leading to more morbidity. What does not appear to lead to more morbidity is the use of therapeutic coma in this relatively large population of 382 patients that underwent therapeutic coma. There was a difference in how they use therapeutic coma in the US versus in Europe. The Europeans seem to be more reluctant to use therapeutic coma than the Americans, but generally the use was symmetric, if not similar. Their final conclusion is the use of therapeutic coma for status epilepticus treatment seems markedly different between centers in the US and Europe and did not affect mortality. However, therapeutic coma may increase length of hospital stay and related cost. That's not surprising, but here's a study that suggests that therapeutic coma is not affecting mortality. In terms of what it's doing to the brain, I'll show you a nice study from Mayo that looked at neuroimaging in patients who are in super refractory status. So this is a patient who had an MRI initially, and this is a follow-up scan after SRSE was treated. So they had, I believe, about 15 or so patients, and they looked at neuroimaging very early on and within a few days after successful treatment of SRSE. The average duration between the two scans was about 40 days, and they noticed a fairly significant change in the amount of atrophy. So what they're looking at is the proportion of ventricular size to brain size. And you notice that that changes quite considerably in these two scans. Here is their graph, and their graph in fact does correlate, the atrophy does correlate with the duration of anesthetic use. But guess what? Duration of anesthetic use is going to be comparable or correlate very highly to the duration of the status. So is it the status or is the anesthetic use? The one paper I did want to highlight just a little bit is a paper by the Harvard group, by Brandon Westover and colleagues, that look at this business of appropriately aggressive therapy. And this is not a bunch of patients that they have, but this is a scientific mathematical formula that they have devised that takes into account the morbidity of treatment and the morbidity of the underlying condition. And what they present is a simple paradigm that when a patient in status or non-convulsive status presents, there is a morbidity associated with the non-convulsive status, and then there's a morbidity associated with the etiology. And a lot of us feel that the etiology is probably a bigger contributor to the morbidity and the mortality than the status epilepticus. So they give a bigger chunk to the etiology, if you will. And then there's a whole bunch of other potential causes for mortality as well, outside of the status as well as the underlying etiology. You've got two options. Either you treat them aggressively or you treat them not so aggressively. If you treat them aggressively, they're going to make the assumption that you're going to stop the status. So if you treat them aggressively, you have the morbidity of the underlying etiology, but now in addition to that, you've bought a little bit of morbidity from the aggressive treatment that you've provided. The second assumption that they make is that if you treat them not aggressively, you will not by any treatment morbidity from the medications that you're using, but there will remain a morbidity from the underlying status and, of course, the underlying etiology. So that's sort of the concept as they do their mathematical modeling. And what they have come up with is a very nice series of algorithms that you can then think about as you think about appropriately aggressive therapy that look at 2 or 3 different factors. The first and the most important is the mortality of aggressive treatment. As the mortality of aggressive treatment increases, your desire to use that treatment decreases. As the disability due to ongoing status increases, your desire to use aggressive treatment increases. So you've got 2 competing things: morbidity of treatment, morbidity of the underlying condition. And so the gray area here is non-aggressive, non-sedating treatment. White area here is aggressive treatment. And you can see for different conditions, absence status, discontinuation of AEDs, intraparenchymal hemorrhage, hypoxic ischemic encephalopathy, the algorithm is different. Your calculus of how aggressive you want to be is different. It is different based on how bad the status is. It's different based on how bad the underlying condition is, and it's different based on how bad your treatment side effects are. And so Larry Hirsch summed this up nicely in an editorial that he published a year or so ago. And these are some of the salient points that he mentioned, and I agree with for the most part. Is what is appropriately aggressive treatment? Well, certainly patients needing aggressive therapy are going to be sicker. Prolonged seizures should be treated very quickly. For intermittent focal seizures, non-sedating AEDs are preferred and should be really tried aggressively before moving on. When seizures are not controlled, then you can consider continuous AED infusion, but you must base that on seizure burden, on etiology, on the risk of neuronal injury, or at least the assumed risk of neuronal injury, and the adequacy of your ICU treatment environment. So I'll wrap that up by telling you that the definition of status is evolving. The definition for non-convulsive status epilepticus and non-convulsive seizures is certainly not clear at this point. Seizure burden is an important concept that we must start thinking of, and it is related to not only short but also long-term outcomes. There are many IV AEDs that are now available. And interestingly, in the last 5 years, we are starting to see a number of randomized trials for status epilepticus. We still don't know what the approval process for drugs will be by the FDA for status epilepticus, but certainly the trials are surfacing. Appropriately aggressive therapy must be based on seizure burden and comorbidity. I'll end by reminding you of this conference that we're putting on in about a year in Washington, D.C. This is the International Federation for Clinical Neurophysiology once in 4-year conference. And you're all welcome to come to that. Should be good information on all aspects of neurophysiology. A couple of things for CME purposes. Here's how you claim your CME in case you don't know. I'll leave that up for a second. And the code for our CME today is up here as well. And I'll end here, and if there's time, answer any questions.
According to the Trinka paper, the T2 for focal status was more than 1 hour. But what is this based on? The Toronto study said 12 minutes of an hour will be associated with bad neurologic outcome, and the Annals of Neurology paper showed that the lactate-pyruvate ratio increases linearly with time. It's not like a step function.
Right, so there's very little data to base any of that information on. Really, the only hard data is probably Eric Lothman's data that looked at convulsive status and looked at 30 minutes as being the point where a neuronal injury started to occur. So a lot of Trinka's and ILAE's summary paper is based on hypotheses and opinions rather than hard data. And in fact, Hahn's paper came out, Cecil Hahn's paper came out after Trinka's paper, so I'm not sure they were privy to that data. But these are loose definitions. This is not hard written in stone definition. That's sort of the point I'm trying to make, is that, you know, the different types of status are different. And Cecil's paper was in kids. Is that going to be different than adults? I mean, I'm sure that will have something to do with it.
Any questions?
Hi, I'm Anumeha Sharma. I'm a junior epilepsy attending here. So your trial with Vimpat and FOS head-to-head for status. So adverse effects you saw similar adverse effects. What was the difference between the 400 milligram dose and 600 milligram dose? I have not gone beyond 400 with Vimpat. I wonder if I should, if they don't stop seizing in an hour or two. I usually switch to another anti-epileptic. We have Vimpat as a second line for focal or subtle status, and I usually switch. So I wonder, should I try 600? And if I try 600, will I see a significant increase in PR prolongation? So what do you...
So I'll answer your question in two parts. First of all, the study was not in status. The study was non-convulsive seizures, and we made that distinction for a number of reasons, IRB being one of them. But having said that, to get to your point of 400 versus 600, my own bias is I think we underdosed with 400 milligrams. I think it should be 600 and 800 milligrams. And indeed, if you talk to Eugene Ramsey in New Orleans, he's routinely using over a gram of lacosamide as a loading dose. I have not done that, but I certainly think that 600 is probably a much more efficacious dose than 400. So you might ask, why did we pick 400? For a lot of sort of convenience reasons. One is that when you're doing a trial like this, you have to get IND from the FDA, and you have to show some safety data. And the only safety data we had was for 400 milligrams. That's the only data UCB had. We didn't have any. But that's the only loading dose data that they had. So on top of that, we added the 200 on our own after that because the patients are critically ill. But in hindsight, I think 600 is a good loading dose followed by another 200 if you need it. Will the cardiac morbidity increase? I don't know. We didn't see any of the cardiac side effects with lacosamide in the 74 patients. But are they reported? Yes, indeed. But they're case reports. Are there reported cardiac side effects with any drug that you give IV? Absolutely. This is no exception. This is a sodium channel blocker, so indeed there's that risk of PR interval prolongation, but we'll see.
Okay, thank you. Yeah, and your point noted about status versus non-convulsive seizures.
All right, thanks.
Thank you.